What does the future look like? Well, I don't know. This is my aid to looking into the future, and it's probably just as effective as really thinking about what's going to happen. But let me at least attempt to do so. So where do we go next? I think trying to understand what causes polycystic ovary syndrome, getting more information about the impact on long-term health, how better to diagnose it, can we be more specific in our diagnosis, and very importantly, and we've heard about this in the last sessions, improving methods of treatment, because there's still a way to go, far from ideal. What do we know about the origin of polycystic ovary syndrome? Well, I'm not going to go into this in detail. We think that it probably starts very early on in life. It's set up during development, and that androgens in early life probably play a role. Obesity is a confounding factor. It makes things worse. It may be causally related. We don't know yet. And one way into this is to do these sort of studies of genetics, epigenetics, how genes are modulated, the effects on metabolism, so-called metabolomics and proteomics. And these are sort of fishing expeditions to look at over a wide range of metabolites or genes to give us clues as to what might be happening. Let me start with that then. So this is just a confusogram, just to give you an idea of the sort of things we're trying to do. So we think that there's one of the possible reasons for development of polycystic ovary syndrome is that there's a genetic predisposition of the ovary to make excess androgens right from the very beginning. And that excess androgen production sets up a whole lot of sort of chain reaction, which results in the features that we recognize in polycystic ovary syndrome. I'm not going to dwell on that, but that's one aspect of trying to unravel the evidence about the origin of polycystic ovary syndrome. We're still working on that, and we hope it will give us some more insights. Another thing is to know more about the genetics. Miles talked about it earlier. We know there's familial clustering of cases, and this is an important Dutch twin study where they looked at identical and non-identical twins. So if there's a very strong genetic component, you'd expect the concordance of symptoms between identical twins to be much higher than in non-identical twins. So identical twins who had evidence of polycystic ovary syndrome on symptoms were much more likely to have a twin with evidence of polycystic ovary syndrome compared with non-identical twins. So that's a very large piece of evidence for genetic factors. But as Miles has said, it isn't one gene. Like type 2 diabetes, there are several genes involved, and one of the approaches is to try and understand what genes are involved. He mentioned the so-called candidate gene approach, where we've probably about 100 different candidates involved in androgen action, in androgen metabolism, metabolic features, ovarian physiology, and of the 100 or so candidates that have been looked at, the result has been a big resounding zero. So that's why people have switched to this anonymous method of looking at the genome in women with polycystic ovary syndrome compared with control. So the principle is that you look at DNA and blood samples in women with polycystic ovary syndrome, and you look at markers, biochemical markers, in or near many thousands of genes. So you're looking at across the genome, whole thousands of genes, and then you're asking the question, are some genes expressed more or less highly in women with polycystic ovary syndrome than in an appropriate reference population? And do these genetic hits give us a clue about what causes polycystic ovary syndrome? So these sort of studies, you need very, very large numbers to be able to show significant differences. And so that's why we now have a worldwide consortium which involves studies at Imperial and Oxford and across the globe, so that you have enough cases and controls to be able to understand what's going on. And then you can generate what's called a Manhattan plot, and you can see why, because it looks like the skyline of Manhattan. And these are all the individual chromosomes and the genes within the chromosomes where there are markers. So each little line of dots here represents a particular marker within that chromosome, which of course contains lots of genes. And what you're looking for is one that pops up above the Manhattan skyline, and particularly above this figure here. And there are several genes which pop up here, and they look interesting. So, for example, FSH beta, so that's the FSH gene. That's really interesting. What's that doing? It's obviously related to reproductive function. So that gives us some clues about what's going on. But there are only clues so far. So we can summarize where we are with the genetics of polycystic ovary syndrome to say genetic factors obviously play a major role in the origin of polycystic ovary syndrome. The early results from the genome-wide association studies look very encouraging. They've pointed up some possible markers, but there's a very, very long way to go. You can look at how certain genes are expressed in tissues from women with polycystic ovary syndrome. It's not easy, of course, to get tissues, but one tissue that you can get are granulosa cells. These are cells which are collected during IVF. You aspirate the follicles. You, of course, look for the eggs. You take the eggs out, but normally you throw away the cells that surround the eggs, the cells from the follicle. But if we ask our colleagues in the IVF lab to keep the cells so that we can look at them in the laboratory, we can look at certain hormones. So here's AMH, which you may have heard about because that's used sometimes as a marker of polycystic ovary syndrome, anti-Müllerian hormone, and it's also used as an index of reserve of eggs in the ovary. And you see that in women with polycystic ovary syndrome, particularly those who are anovulatory, there's much more gene expression of AMH, so the cells make more AMH. That's just one example. You can look at protein, and that very pretty picture here is looking at androgen receptor protein. So what do you know? Androgen receptor is present actually in the ovary. It is in the normal ovary, as well as in the polycystic ovary. And these little green dots here are the granulosa cells of the ovary. There's the egg, and that's the antron of the follicle. So you can look at proteins as well. You can do a more complicated protein analysis called proteomics and look at a whole range of proteins. And you can look in ovarian tissue, follicular fluid, serum, adipose tissue, and you see these hits coming up. So that all looks very good. And how do you make sense of that? Well, not easy, because I don't expect you to read that. But current challenges in the application of proteomics to the study of polycystic ovary syndrome, the fact that there are 7 here and there are probably more tells you all you need to know. A long way to go here. But we may be able to see proteins which are differentially expressed in women with polycystic ovary syndrome, which gives us a better idea about what's going on. So watch that space. It is important, we've heard a lot about the impact on long-term health. It is important we have more information about this. And what are we worried about? Well, we've heard really the main thing is impaired glucose tolerance and type 2 diabetes, but diabetes of pregnancy is also increased, and there's a question mark about cardiovascular disease. Now, as far as diabetes risk is concerned, the odds ratio tells you the relative risk, so here's type 2 diabetes, that's impaired glucose tolerance. It's 3 to 4-fold increase in women with polycystic ovary syndrome overall, and that's as a result of so-called meta-analysis, where you've looked at lots and lots of different studies. It's not absolutely reliable, you need longitudinal studies, but it does confirm the increased risk of diabetes in women with polycystic ovary syndrome. But this is interesting. This is the North Finland birth cohort study that you've heard about earlier from Terhi. And I want to point out what's going on here. We're looking at the odds ratio, again, the relative risk of getting diabetes. And if you're overweight and obese, you've got something like a 3-fold increase of getting type 2 diabetes at the age of 31. But very importantly here, if you're lean, and this is, of course, in the context of a population, the normal population, in which there are women who have symptoms of polycystic ovary syndrome. So in this population study, it suggests that if you're lean and you've got polycystic ovary syndrome, there isn't an increase in risk. Now, that may be open to question because it's relatively small numbers, but it does really emphasize the importance of the interaction between polycystic ovary syndrome and obesity in conferring extra risk of diabetes. Cardiovascular disease, again, we've heard a bit about this and the uncertainties, and I think the most important thing is the bottom line here. There are the risk factors, but at the moment, no conclusive evidence that women with polycystic ovary syndrome are more likely to have heart disease. We don't have enough studies of longitudinal studies of women into their 60s and 70s, when, of course, you'd expect there to be a higher incidence of heart disease. But so far, there are no firm data to suggest, although the risk factors are there, you are at increased risk of heart disease. That doesn't mean to say we shouldn't be aware of the risk factors and make sure that they're reduced as much as possible, because we can't be sure that there isn't going to be an increase in heart disease. But so far, it's looking quite reassuring. Improving diagnostic methods. Well, this is where this so-called omics technology might come in. In other words, we can uncover markers either from looking at DNA or metabolic profile or proteins, which will give us a better clue to diagnosis. But that's still very much a fishing expedition, and we don't have anything clear at the moment. And finally, improving methods of treatment. So we can do better with the current treatments that we're using. We haven't got very many specific treatments, but Terhi or rather Lisa mentioned the use of aromatase inhibitors, letrozole, which looks very promising. We need more data for treatment of fertility. It will be better to have better androgen receptor blockers to reduce hirsutism. That really is quite important. We can't see anything on the horizon at the moment, but something that I think is very important to develop. New weight loss drugs, Harvey has told you about that, and the future looks quite bright there. So we're hoping that those will come in. And I think that's a field where, and I think the information from the bariatric surgery and the hormone changes that you see there is beginning to point to what hormones are important in maintaining weight loss. And so maybe using that information to develop new pharmacology will help to reduce the need for bariatric surgery. But at the moment, as you've heard, it's jolly good treatment. And so finally, the application of these omic methods to identify particular genes and proteins that we might focus on to provide personalized treatment. So each woman, of course, will have a different genetic profile, and maybe, and this is the idea of personalized medicine in the future, we'll be able to do that in the future for women with polycystic ovary syndrome. Thank you. Oh, let me summarize this. So understanding what causes it, that's important. Understanding the impact of long-term health, need for longitudinal epidemiological studies, improving diagnostic methods, and particularly improving current methods of treatment and thinking of new methods of treatment. Thanks.